Yes, my name is Greg Rayburn, and this is my program for Aspen University on my final research project for our research class. I call it Elderly plus Confused equals more falls. No more. Okay, the problem we have in many long-term care health facility is that you have a lot of falls. It's one of the more tragic events that takes place in long-term care facilities regularly. Um, but one of the areas that adds insult to injury, so to speak, is when you have confused people. Studies show that confused people just fall more often, and there really hasn't been a definitive answer to solve this problem. But one of the problems that elderly people have is that so much slows down when you become elderly, and the older people become more vulnerable. Their immune system response is weakened. Healing takes place slower. Motor skills slow down. Bone density becomes less dense, and your reflexes slow down. But the issue I want to talk about in this presentation is the cognitive abilities of seniors leads to falls, and that's been documented. Often falls are devastating for seniors. Falls, as many of us know, are a leading cause of injury and death among seniors. Seniors heal more slowly if complete healing takes place at all, and it is paramount to stop falls before they happen. Stopping falls often is easier said than done. Studies show that confused residents are at a higher risk for falling. Staffing can be a problem. Staffing, we would love to be everywhere in a facility all the time, to be omnipresent, but the problem is that's just not realistic. We would also love to have one-on-one sitters with all cognitively challenged seniors, but this isn't practical because there are too many confused people in a long-term care facility for the most part to follow every person all the time. Staffing shortages would just make it impossible to be everywhere all the time in a long-term care facility. So what can we do to reduce the tragedy of falling by cognitively challenged people in long-term care facilities? What can be done? Well, here's a possible answer. Placing them closer to the nurse's station um, when we give them a room. Okay, how would this happen? Well, how would this help? Well, first of all, if a person is near a nurse's station, then that's the place where there's the most activity in a nursing home. There's more people there generally, so there's more eyes and ears to spot potential trouble. I specifically said ears because sometimes there's sometimes noise before a person falls. You hear a strange noise, you hear something out of the ordinary, maybe a cup or a dish falls to the ground. And then that can indicate to you that a fall may be imminent, so you can more hurriedly investigate what's going on to stop somebody from potentially hitting the floor and hurting themselves. So here would be my plan. Whenever there is a new admission, for people who are classified as cognitively challenged, place them closest to the nurse's station. If there are no rooms available, and if a new admission is cognitively challenged with a fall history and an unsteady gait, try to relocate a low risk fall patient further away from the nurse's station. If a current resident falls who is cognitively challenged, also relocate them closer to the nurse's station. The idea is to make the nurse's station the rooms closest to it for your highest risk people to fall in. Now, what would be some potential drawbacks? Well, depending on, there generally would probably be too much demand for supply. There probably are too many cognitively challenged patients versus the number of available rooms. The majority of people in nursing homes, they have confusion problems. So there are not enough rooms to put every cognitively challenged person near the nursing home. Some non-confused residents, another drawback, may not want to give up their rooms because some people hate change. This barrier would be overcome through trying to use persuasion. However, what would be lost to at least try this program? I mean, what can be lost? The worst that can happen is elderly people will still keep falling at the same rate. Better to try something than nothing. Now, keep track of falls and near falls. That would be our documentation. Track how many falls took place in the past 12 months. That would be internal evidence prior to the launch date. Using this would be quantitative method using statistics. See how many of these falls were cognitively challenged people. That would be internal evidence. Also track monthly how many falls took place and determine if the new placement policy had any impact on reducing or preventing falls. Now, this would also be part of the record keeping and research. Make management do the paperwork on this program, because if floor nurses are mandated to do it, it probably won't get done, especially dealing with near falls. If floor nurses are given another job to do that they perceive as simply draining more of their time out of their day, they will try and find ways to get out of doing it because they already have too much to do anyway. If management wants accurate records, they need to take ownership of the paperwork and do it themselves. Information to track. How many falls took place near the nurse's station after the plan began? Were the falls serious? Were they falls without injuries? Did the location of the room have any bearing on the falls, near falls, or the absence of falls? Was there any unanticipated stress on patients asked to relocate to a different room so there could be more room made closer to the nurse's station for residents who are more cognitively challenged? In other words, you want to see if this new program causes any unanticipated collateral damage. We don't want anyone hurt. In other words, sometimes older people, sometimes a change in the routine can just bring confusion. And confusion sometimes can bring falls or other related unanticipated problems, which we would want to document in this new plan. Now, this would be also helpful to the research, and it would be by some be perceived as extreme. What I would do is I would hire a temporary hospitality aide during the test period, whose real job actually wouldn't just be doing hospitality, it would be observation during the hours the top managers typically are not in the facility, which would normally be evening or nighttime or weekend hours when management normally is never found, unless there's a problem. Only the director of nursing would know about this employee. The objective of this hospitality aide would be to report to the DON to determine how effective the program is working during non-peak hours. The purpose, because if management staff does because if the management staff does non-peak hour observation, the regular staff will act like they're on their best behavior, and a true clinical picture will not be captured about what impact this change will have in a real world in the long term. We all know when the cat's away, the mice play. However, when the cat's there, the mice aren't going to play. What I mean is, when you have top management there, people are going to go by the book. They're going to do what they're actually supposed to do. And sometimes when you do not have management present, this isn't how it's supposed to be, but this is how it is. They're going to do their job, but they're going to not doing everything the way when the manager's present. That is just the reality of how it works in many nursing homes. Why hospitality aid? Why would I want a hospitality aid to do this? Well, because these types of employees do not need licensing, so they're easy to hire. Also, they present no authority or fear factor for other staff members to act on their best behavior. Okay, the point is the DON wants to know how this program is really working and not present so it can not present a clinical picture that looks impressive but really doesn't do any good. In other words, what I would want to know is what impact this new policy is having when I'm not around. And the only way I'm going to be able to do that is have another observant pair of eyes to see. Okay, because if I have a co-manager there, or if I'm going to be there, then what's going to happen is the regular floor nurses and the aides are all going to be acting the way they're supposed to instead of what they're all going to be going by the book instead of what a lot of times people do when management isn't there, which is they just do things differently. Now, I call this more or less the Midway analogy of research. Now, what do I mean by Midway? Well, it's a historical reference. In 1942, there was a great battle in World War II called the Battle of Midway. Now, this took place, if you know anything about World War II history, and on December 7th, 1941, the Japanese surprise attacked the United States Navy in the area of Pearl Harbor, where most of the United States Navy was decimated. A surprise attack, and that led us into World War II. Approximately 7 months later, there was a very important battle called the Battle of Midway, where which was going to basically lead to who was going to win World War II in the Pacific theater. Well, what happened was this in the Battle of Midway. 4 Japanese aircraft carriers were destroyed by the United States Navy, and only one American aircraft carrier was destroyed by the Japanese Navy. So what happened was we as an American perspective, we destroyed 4 of their carriers and they destroyed 1. So what that did was that led to the United States eventually winning World War II. Now, why am I bringing that up? Because one of the most impressive parts of the American victory at Midway was that our intelligence, which is a type of research, our intelligence over where the Japanese were before and during Midway, our intelligence was far superior to the Japanese intelligence about where we were. And that was one of the main reasons why we won that battle. And so the point I'm trying to make is this: quality research, whether it be in military intelligence or in healthcare or whatever, quality research will lead to, especially in healthcare, will lead to better results. Okay, sometimes in healthcare, people come up with a plan, people just nod their heads, even though they really don't mean it, and everybody just says, oh, you come up with a wonderful idea, and nothing ever really changes. But if you have quality research, okay, then it can actually lead to higher quality healthcare provided to patients, and in this case would be reduced falls. And if I had an aide that were there just observing, not trying to get anybody in trouble, but just observing if it made a difference, then that could make all the difference in the world. Now, these are my references, and my name is Greg Rayburn, and this is for my research class for Aspen University. And I want to thank Dr. Jimmy and anybody who had anything related to helping this program. You have a wonderful day, and thank you very much.